Well, thank you very much for inviting me to kind of share the experience of incorporating clinical geriatrics into HIV care in the UK, specifically in Brighton. And I know it's the last presentation, so I'm the only thing that is stopping you from actually going out and enjoying the Friday, but trying to be brief. These are my disclosures. So this is no surprise to you. It is the same in the UK. The number of people aging with HIV attending care is increasing. And that's a situation. In the UK now, it corresponds to probably more than 50% of people living with HIV over the age of 50 years old. Now, Brighton is a particular place in the UK because we have the oldest cohort of people living with HIV in the whole of Europe. We have a cohort of approximately 2,400 patients living with HIV. And there are reasons for that, because Brighton is a fun place. It's by the coast, it's warmer, considering the UK, on those standards. And so lots of people tend to go to Brighton to retire, including aging people with HIV, particularly coming from London and other places. So we get a constant influx of people actually transfer care to our center. So in the UK, our cascade of care is excellent. 99% of people are aware of their diagnosis, are on treatment, and 99% of them are actually undetectable. So the HIV medicine that I do in Brighton is probably looking more like this. Stable patient from the HIV point of view, undetectable, usually with good CD4 counts. But I don't have to tell you, because I did the presenters earlier, kind of demonstrated very nicely all the complexity that patients do have now. And this is just an example of one of my patients with all this complexity, not only multimorbidity, but also polypharmacy, but also very complex sort of social demographic issues, and mental health disease as well, that in situations like this can present with geriatric syndromes very, very often. So, okay, moving. Oh, it's moving now. So this is really what is happening. And again, I don't have to explain this because it was really nicely explained earlier. But in the UK, really, the patient's expectations is that HIV services are going to be the coordinators of care. And we do take that role of trying to coordinate all these services. But ultimately, the patients have to navigate all these things. And absolutely right, I have patients that, for example, get 2 appointments at the same time. And they have to actually phone and trying to decide, okay, am I going for the scan, or am I going to the physiotherapy appointment? What do I do? So there is a lot of complexity there, and we expect sometimes patients to actually navigate all this. So what are the clinical pathways there for people with HIV with geriatric syndromes and complex multimorbidity? So in the UK, really, you could send them to the primary care physicians, general practitioners. Already they are overburdened because this is a situation that is happening not only in people with HIV, but also in the general population. As we heard, you can start sending patients to different specialties. But what's happening really, at least there, and it's something that we haven't really talked here, is about issues like a stigma, for example. A lot of patients that have fear of a stigma, healthcare-associated stigma, they also have to face multiple appointments and also services that are not quite familiar with some of the complexity of managing people with HIV. Even to the point that a lot of the other specialties, for example, think that everything is caused by HIV or the medications, when in reality it isn't. So I think all these things kind of create some difficulties for patients. We've been in this conference, you have discussed some of the potential models of care that are also, potential solutions, but also there are struggles there. One of them is combined geriatrics and HIV care models. And that's what we did in Brighton. And in this clinic has been running since about 2012, so we started quite early in this process. And it's really what the geriatricians do. And I think yesterday, very nicely, it was explained what the sort of 5 M's is. And in the case of the Silver Clinic, we do this clinic once a month. It's about 40 minutes to an hour per appointment. We have 2 geriatricians doing it. And then is the HIV physician that is going to look at the specific HIV issues, not only in terms of changing therapy, but also navigating some of the services, because HIV services know where to send these patients and have specific pathways for these patients. The main output really is an individualized care plan. So this is patient-centered care. And I think geriatricians were pioneers on patient-centered care, because that is really done very nicely. That then is actually shared with HIV clinics or the physicians, we don't want to replace the IV doctors or the HIV physicians. They continue looking after that part. We share it with other hospital specialists and also with the GP. So that's the main output of that process. These are some of the assessments that we do, very simple form that is done electronically, and these are some of the assessments, physical exams, things that again happen within the comprehensive geriatric assessment. We also use a lot of patient-reported outcome tools to actually help us during the consultation to identify that first M that is so critical, what matters most to patients. So patients have the opportunity to tell us what exactly is that they want that consultation to address, because it's what is concerning them more. So this is really what we do: address polypharmacy, optimize the management of comorbidities, supporting patients with navigating all those social problems and psychological issues, and formulate some of these health interventions, including social prescribing. So exercise programs, for example, managing things like social connectedness, and so on. And really the objective is improving quality of life, and that's what we want to do. We want to improve quality of life and well-being. So the referral pathway, and now we're going to talk a little bit more about implementation. So initially, when we set up the clinic, the main referrals were coming from HIV physicians that were struggling with, with these patients, managing them just with 20 minutes, because that's the sort of model of care that we tend to have in the UK, only 20 minutes. But we decided then that we wanted to start looking for patients actively. Can we identify those patients that are frail so they can actually benefit from a service? And in the UK, we do an HIV annual health check, which happens once every year. It's about 40 minutes appointments. Nurses do a lot of assessments, including assessments of mental health, cognition, and so on. And we started thinking about implementing frailty screening at that process to be able to start getting more patients through the clinic. This was on the back of some of the work that Fatima Brañas from Spain, as part of the EI guidelines in 2021, proposed an algorithm for frailty screening that suggested that we should be screening people over 50 years old, suggesting some tools, and then those that were identified as frail could then have a comprehensive geriatric assessment and have some sort of geriatric evaluation. But the problem with guidelines, as it is sometimes, is that you don't really get all the answers, particularly the implementation science answers. What are we going to tell the patients? How are we going to sell this screening? Are we going to start screening just like this without actually telling patients who is going to do it? Is it going to be the nurse? Is it going to be, it's going to be the doctors? Who is going to do it? How often should we do it? Twice a year? Patients tend to come twice a year to the clinic. Are we going to do it during the annual health check? How are we going to do it as well? What tool are we going to be used? And what's going to happen next? So we're trying to kind of break this down a little bit and trying to kind of do some of this work in terms of co-production to be able to implement the whole pathway. So this is some work that one of my PhD students, Natalie, has done very nicely, just looking at the perceptions of patients and healthcare professionals on frailty and the implementation of frailty and screening in care services. And it was just simply asking patients about what do they think about frailty, about the concept of frailty, about the language that we use to actually sell this. And for many patients, it was actually quite positive in many ways, because they could be more proactive in terms of doing something about this. In terms of the concept of frailty, and I know that in the geriatric world, there is a lot of discussions about the language and the stigma associated with aging and even with the word frailty. But I think it's all about how we explain what we're going to do and why we're going to do it. I think patients really want to know that you're going to be testing for something, you have something to actually offer. And also in terms of when to discuss frailty, and this is interesting because for a lot of patients, they wanted this to actually happen at the sort of routine HIV clinic, although some patients were kind of happy to kind of have it done also at the GPs. And again, they didn't really mind about the tool. They just want the healthcare professionals to actually decide on that. And then it comes to the tool. And, there are very fancy tools. We all talk about validation, and actually validation requires a really, really string process. There are a lot of tools there. And we actually work with the healthcare professionals about which is the tool that was more implementable in our own service. Because you might say walking speed is really easy to do, but actually there are clinics that don't have the space and the nurses are very busy, so they're not going to take 5 minutes to be able to do this. So a lot of the nurses say, no, we're not doing that. In the end, we ended up with the Frail scale, which was quite simple tool, 3 minutes, patients can complete it themselves before they actually come to the annual health check. And we decided, you know what, we're just going to go with that. It's been validated in the general population. We might be able to identify at least those that the most sort of complex population in our clinic. So this is just a summary of our pathway, and this is happening right now because we have implemented this in general practice. Once a year, the nurses do a screening, and notice here that we started the screening over people over 60 years old and not over 50s, because the nurses said, we have 68% of our patients are over the age of 50. We're not doing this because otherwise that's all we're going to be doing. So we decided, fine, well, let's do it over 60 years old using the Frail scale. If someone is identified with this tool as robust, then just recommendations for healthy living and social prescribing, what a great opportunity to sell all these sort of positive things about exercise and diet and so on. If someone is pre-frail, we let the GP and the physicians know. And again, the same recommendations. And if someone is frail, then we offer an appointment to the geriatric HIV clinic. So this is our experience. We kind of published this, just experience of doing this, and we did a little bit of this during COVID, which was, I mean, quite impressive in terms of the nurses. Of the 590 sort of people living with HIV over 60 years old, we managed to actually screen about 77%. So that's quite good for something that just started really from kind of discussions with patients and healthcare professionals. And about 12% of them were screened as frail. We also kind of triage some of the pre-frail individuals that we consider could actually benefit from this intervention. But interestingly, not everyone that is identified as frail want to come to the clinic. For some patients, they were like, you know what, I don't want to, I'm just too busy now, or I'm really at home most of the time. I don't want an extra appointment. So I started thinking about how services need to adapt to this. This is, again, just to show the sort of characteristics of these patients. The population in Brighton is quite specific. Mainly, we have a lot of men that have sex with men of white ethnicity. And you can see here that the age of these patients, particularly the frail individuals, they're quite young, about 10 years younger than you will normally expect in a geriatrics clinic. And these are the sort of things that we tend to see in the clinic. You know, frailty syndrome, a lot of geriatric syndromes, a lot of mental health problems, issues with mobility, falls, cognitive decline, social isolation. So this is not very different from all the things that we have discussed here. What we wanted really to do next was to kind of provide some evidence that doing a comprehensive geriatric assessment in an HIV population has actually an impact, not only on quality of life, but potentially on frailty outcomes. So we did a kind of feasibility and acceptability study, a mixed methods study, randomized control trial, which we presented recently at IAS. And this is interesting because I think comprehensive geriatric assessment has been used in different settings like cancer care and cardiology, and there's quite a lot of evidence that it does work, but not in HIV. And what we've seen with this study was a signal that potentially comprehensive geriatric assessment actually can improve quality of life for patients, and also can improve some of these frailty measures like walking speed. This is very important because if we're going to be selling these models of care, this is information that we need to go to health commissioners to say, look, we need more of these services because actually it's improving quality of life and it's actually preventing people from going into frailty or potentially reversing some of that process. But more importantly is that people actually really like it. Of course they do. Patients have an hour with 2 physicians that are listening to them, right? And that makes a huge difference. It does make a difference. So they really, really like it. Healthcare professionals also really, really like it because they have this complexity, only 20 minutes, and they were able to actually send patients to kind of have a more enhanced care. So what are my tips then if you're planning to do something similar? And I'm not saying that you need to go now and set up combined and HIV geriatric clinics, okay? But you really need to start building the evidence. How many older people living with HIV you have in your service? Start doing some service planning. Start thinking about what are the existing services that I have in my setting? Do I have falls team? Do I have continence teams? Do I have all these services that maybe I can go and talk to them? And you would be surprised that a lot of physicians don't know about this, particularly about HIV, and they get very interested about our populations. Do education and training, not only of other healthcare professionals, but also of patients, because patients need to kind of know about this and understand the benefits, for example, of some of these social prescribing. and always involve patients. I think co-production is absolutely essential for things to actually work. You really need to talk to patients, and we have an advisory group, a patient group in our service, and any intervention that we're going to be implementing, we actually discuss it with patients, just to make sure that it's going to work. But it's not the only model, and we need to kind of be flexible here and adaptable. We need to think about other ways of doing this. Virtual case management, for example, you can do this without actually seeing the patients and still have an impact potentially. There are new things, particularly in the UK, things like virtual wards, home care. There is a lot of technology coming. Can we use that? And also we might need to kind of get out of the clinic and actually go to the patients' houses and care homes to actually look after patients as well. So it's just thinking about the flexibility of these models. So this is my summary. It's the last slide, really. Frailty screening and management. I think what we've shown is that we can do it, right? Brighton is a busy service, it's a big clinic, and we were able to actually implement this. So we can do it. That's one thing. Of course, there are challenges there. There always are challenges, and we need to be adaptable. And I think multidisciplinary collaboration is essential here because this is multidisciplinary management, it's patient-centered care, and also the patient involvement is absolutely essential. Always involve the patients. But I want to finish with this because I think what we're seeing here is how resilient our patients really, really are. And this is a quote from one of our patients that contributed to one of the studies. They said, we are fragile, but we are very strong. And I think we need to capitalize on that resilience. It's very important. There is a lot of negativity with aging and HIV, and I think we need to kind of change that and start thinking that we can do this. We can actually improve our services so we can get the patients on board to actually do this together. And with that, I'm just going to finish now, and just some acknowledgements of some of actually the geriatricians and the nurses that are actually involved in the clinic. Thank you.